Your patient has type 2 diabetes and a stent in their left anterior descending artery. You've been prescribing Tirzepatide for 2 years. Better A1C, better weight loss, better lipids. By every metabolic measure, they're winning. Except the insurance formulary just changed and they want you to use dulaglutide. Do you fight it with a prior authorization or appeal? Do you cause patient and clinical staff stress while they wait in limbo? Maybe the actual question you should ask is, will the patient actually live longer? A new trial just dropped with the answer. In this week's episode, the PICO is in adult patients with type 2 diabetes and established ASCVD. Does Tirzepatide reduce major adverse cardiovascular events, or MACE, compared to dulaglutide? This was a double-blind, active comparator-controlled non-inferiority trial. And if that design sounds familiar, it's because we've covered this exact framework before. Link in description. When a drug class already has established cardiovascular benefit, you can't ethically randomize patients to placebo. So the bar then becomes, is the new drug no worse than the one we already trust? Eli Lilly designed the trial in collaboration with an academic executive committee, conducted across 640 sites and in 30 countries. Patients were enrolled if they had type 2 diabetes with an A1C between 7 and 10.5%, and a BMI of at least 25, with documented ASCVD in at least one vascular territory. Tirzepatide was titrated from 2.5 milligrams up to a maximum of 15 milligrams weekly. The comparator was dulaglutide at 1.5 milligrams. You'll know dulaglutide as a GLP-1 receptor agonist with some cardiovascular benefits shown in the REWIND trial. To maintain blinding, dulaglutide patients went through a sham dose escalation scheme. Non-inferiority was defined as an upper confidence interval limit below 1.05 on the hazard ratio. And if non-inferiority was met, they would look for superiority. The primary endpoint was a composite of cardiovascular death, myocardial infarction, or a stroke, 3-point MACE. After excluding patients that were randomized in error, the modified intention to treat population included 6,500 patients in both arms. The mean age here was 64 years, with 30% being women, a mean A1C of 8.4%, mean BMI of 32.6, and a median diabetes duration of 15 years. Nearly half of patients had a prior MI, and at 36 months, 73% of the Tirzepatide patients were on the maximum of 15 milligrams. Here's where it gets interesting and worth slowing down for.
Slow down. Slow down. Please slow down.
Tirzepatide produced meaningfully better metabolic outcomes across the board. A1C dropped by 1.66 percentage points versus 0.88 in dulaglutide. Body weight fell by 11.6% versus 4.8. Triglycerides dropped 24.2% versus 10.2%. Systolic blood pressure had a modest reduction of 2 points. By every surrogate we track, Tirzepatide was the dominant drug. And then you look at the actual outcomes. 3-point MACE occurred in 12.2% of patients taking Tirzepatide and 13.1% taking dulaglutide, with a hazard ratio of 0.92 and a 95% confidence interval of 0.83 to 1.01. Non-inferiority was met and superiority rejected. None of the individual components like cardiovascular death, MI, or stroke reached statistical significance on their own. All-cause mortality did tell a slightly different story, 8.6% versus 10.2%, with a hazard ratio on the correct side of 1. That's a significant reduction in death from any cause, driven largely by fewer non-cardiovascular events, like infection deaths that were nearly halved. The expanded MACE-4 endpoint, which added coronary revascularization, did reach significance, a hazard ratio of 0.88 with a 95% confidence interval of 0.81 to 0.96. However, looking at the subgroup analysis leads to some skepticism. While most were not significant signals, region and A1C at baseline are important to look at. This study continues to do something that drives me bonkers.
Completely bonkers.
In America, we take results from this and similar trials and apply it without thought. But looking at the region, only about 15% of patients were from North America. And the region that drove the results is Europe, with the largest patient block and nationalized healthcare to boot. Would you say that lettuce is safe to eat if only 15% of the samples came from the affected farms? No, you would want more data and maybe more studies. Secondly, lower A1C at baseline showed better results for Tirzepatide. Is it because these patients are more adherent? Maybe. Maybe they required less diabetes meds, leading to fewer overall side effects. All this is to say, that, especially with data that is unconvincing at best, there are reasons to further evaluate any action. For safety, gastrointestinal events were higher in the tirzepatide group, 42.5% versus 35.9%. Severe hypoglycemia was identical and low at 0.7% in both arms. There were 2 cases of medullary thyroid cancer in the tirzepatide group, but none in the dulaglutide group. This was a rare finding, but we should still flag it. So the SURPASS-CVOT trial earns a Castelli Coefficient of 1 out of 10. Wait, if you've watched all the previous videos, you know that's not right. It's actually a 7.5 out of 10.
Good news, everyone!
But the 1 is in there somewhere, because if I'm being honest, we may not have learned a whole lot. Here's why it lands at a 7.5 and not higher. The trial did exactly what it set out to do, and that's the problem. It proved tirzepatide is no worse than dulaglutide. Full stop. What it can't tell you is whether tirzepatide is better than placebo in this population, better than semaglutide, or whether all the metabolic superiority actually buys anything at the cardiovascular outcome level. Tirzepatide lowered A1C by nearly twice as much, more than double the weight loss, and triglycerides were down 24%. But MACE was essentially identical. The metabolic paradox is real, and it's unresolved. The score would be higher with a comparison of semaglutide, maybe a placebo arm, or if any single MACE component had crossed the superiority line. What keeps it at 7.5 is the design rigor, 4-year follow-up, hard outcomes, and the all-cause mortality signal, which, while exploratory, is one of those more interesting numbers in the paper. And please don't forget what is buried in the supplemental appendix. I know it's hard and expensive to conduct trials in the US, but applying results of a trial when so few patients were actually from here can be a problem. So what does this mean for the patient in your office that has a stent? Tirzepatide is safe from a cardiovascular standpoint. It won't hurt them. And if metabolic control, weight loss, and kidney protection matter for that patient, they probably do. Tirzepatide remains a strong choice. What SURPASS-CVOT can't give us, though, is cardiovascular superiority argument over other GLP-1s. And until we have a head-to-head against semaglutide, the question stays open. It leaves you to wonder, how hard should you fight with the insurance company to get tirzepatide covered over some other GLP-1? I don't know, and that's up to you and the patient to decide. Until next time, this is Dispense as Written.